Hello and welcome back for part 2 of the abdominal examination. We've done general inspection of the patient and we've done more specific inspection of the abdomen itself, and now we're going to do palpation and percussion. We're going to feel the abdomen and we're going to tap on the various structures related to the abdomen to help us understand what's going on with the patient. And why do we want to understand what's going on with the patient? It's because we care about them, because they are valuable. They are precious individuals made by God, and we want to take really good care of them. So with that in mind, let's proceed into this topic. So again, an overview to remind you of where we have been and where we are going. We've talked about the positioning of the patient and the environment in the room. We've talked about inspection. In deference to McLeod's, I'm going to leave auscultation till the third lecture, but just know some people say you should do auscultation before palpation and percussion because you don't want to stir up the abdomen and stir up the bowel sounds before you have a chance to listen to them undisturbed. Now we'll do palpation and percussion, and we'll finish with auscultation and then other tests and special maneuvers. So before you begin, especially important with the palpation and percussion, not only do you want a warm environment, you want warm hands. So warm up your hands before you touch the patient, because we want their abdomen to remain soft and relaxed, and cold hands don't help. We want the head of the patient on a pillow with them laying down. So the patient supine with a pillow, because again, we want those abdominal muscles relaxed and the patient comfortable. We may need to kneel down if the bed is low. We want to be able to hold our right hand flat against the abdomen, and so kneeling may help us do that. It honestly may also help with your inspection, which we didn't mention in the inspection lecture, but being able to see across the abdomen might show any abnormalities of the contour and whether or not there's a mass or anything like that. And then lastly, before we touch the patient, always ask about pain, because we're going to start away from the site of pain and work toward it, because we want to get the best abdominal exam possible. And if we start where it's painful, they're going to tense up and it will make it very difficult to feel anything in their abdomen. As I said, when we palpate, we'll use the flat right hand. We're not so much using our fingertips as we are using the distal parts of our fingers. When you begin to palpate, you're going to start with light palpation away from the pain. And after you've done every region of the belly, those 9 different areas of the abdomen, in the iliac fossa on the right, of the patient, and then moving up to the flanks, and then moving up to the right upper quadrant, then moving up to the epigastrium, then the left upper quadrant, all the way around. You want to just palpate every area of the belly superficially, and then you're going to return and do that deeply. And you're testing abdominal muscle tone with just short dipping movements. And you're also trying to investigate and explore where exactly is the pain and how does the patient respond when I press on the abdomen. You're also going to look for a mass of any kind. Those could be enlarged organs, or it could be a separate discrete mass in the abdomen or in the abdominal wall. And when you just find one, you wanted to map it out, describe it. Remember your CS1 course, remember SPACE SPIT, the acronym that you can look up again in McLeod's, but with size and position and attachments and consistency, etc., etc. You want to go back and look at that to be able to describe any mass you find. And then when you do find a mass, you want to figure out, is this an enlarged organ or is it not? And I've had many opportunities in my medical career to be confused on this point. You begin feeling, you're like, oh, well, there's a mass there. And then you realize, no, it's just all one huge liver or one gigantic spleen that's extended across the belly because of malignancy or infection or whatever. So do take your time and try to map things out and describe them. Okay, and then a word specifically about where you're going to palpate. Again, I mentioned palpating in every region. These are two different ways you can divide things up. So one, you could palpate in the right iliac, right lumbar, right hypochondriac, epigastric, left hypochondriac, left lumbar, left iliac, hypogastric, and then umbilical. That's one way you could do it. Or you could go right lower quadrant, right upper quadrant, left upper quadrant, left lower quadrant. Just two different ways of doing it. Obviously, the one on the left is more detailed, and it gives you an idea, too, of the structures that are beneath the surface when you're palpating those areas. Another look at that is here, a reminder. And this diagram specifically is from McLeod's, so it's a diagram you can study. I do think going back and studying all the pictures in a chapter of McLeod's is a great way to study. But again, just reminds you of where the aorta is located, where the right kidney's lower pole is located, over here. Where you can potentially palpate hard feces here, even in the left lower quadrant, where it might be a mass that you can indent with your finger. That would tend to be feces, and if it's in those correct regions. So just a reminder of where the distended bladder is, where small lymph nodes might be, etc., when you palpate the abdomen. Also, as you feel and you're feeling for pain, it doesn't talk a lot about this in McLeod's, and we haven't talked a lot about it because we want to focus on normal examination, but you want to pay attention to when I push down, is the abdomen rigid? That is, the patient's not trying to make the abdominal wall really tight, but it is. It's more of a reflex to an intra-abdominal process. Or when I press down, is there guarding, which means the patient is tightening their muscles to protect themselves as I press down. Those are both ways, both abnormal findings that it would indicate a problem in the abdomen. Also, when it comes to a mass, if you're not sure if it's inside the abdomen or in the abdominal wall, one way you can do it is to have the patient raise their head up off the pillow and tighten their abdominal wall muscles. If the mass remains visible and palpable, and or palpable, I should say, then it's in the abdominal wall. If it's obscured by that maneuver, then it's inside the abdomen itself. So all of these are maneuvers you can do. The jar sign, where you bump the table or have the patient stand up and then get on their tiptoes and then drop down where their feet are flat. Those also indicate peritonitis or an intra-abdominal process. So all these little tests you can do, but we want to focus on normal examination. I just want to mention them so you're aware of them. So this is an example of what you might find. Again, I mentioned these different regions of the belly. So you have the right iliac fossa down here. That's where you can maybe pick up cecal cancer, Crohn's disease, appendiceal processes. You can move up into the right upper quadrant and you might find hepatomegaly. You might find evidence of an aortic aneurysm up here in the epigastric area. The spleen can be in this left upper quadrant, or you see a list of all the other things that can be located up there. And then this is just a map. It's a diagram from McLeod's that you can refer to and study if you like. What am I looking for? If I find abnormalities in these areas, what are they? This gives you a good differential to work through. So after we've palpated the abdomen more generally, we do want to take time to palpate the liver and the gallbladder and the spleen. The kidneys you will palpate as well as part of an abdominal examination, but because we're in the gastrointestinal system, I'm going to leave that alone for now. We'll cover that when you guys are in the genitourinary system. Okay? A word about the gallbladder before I show you guys a video of the palpation process, just to show you how it's mapped out according to McLeod's, give you an example to follow, just to watch it being done. When you're palpating for the gallbladder, you're going to ask the patient to breathe in deeply, and you're going to gently palpate in the right upper abdomen in the mid-clavicular line. If your fingers happen to touch the inflamed gallbladder, that pain will cause the patient to stop breathing. They will halt their inspiration. We call that Murphy's sign, and it typically goes along with cholecystitis, or inflammation of the gallbladder. And so that's, something you might find, or you might be looking for as you explore trying to feel the gallbladder. Most of the time you won't be able to feel the gallbladder discreetly. This is one time when you have evidence that you've touched the gallbladder and that it was inflamed or diseased.
Do you have any pain anywhere?
No.
I'm just going to feel very gently. Let me know if it's sore.
Ensure that your hands are warm and sit on or kneel beside the bed. Use your right hand, keeping it flat in contact with the abdominal wall, and avoid using your fingertips. Watch the patient's face for any sign of discomfort throughout the examination.
I'm now going to feel deeper. Again, let me know if it's sore.
You should feel each region of the abdomen in turn with superficial palpation, and then repeat with deeper palpation. If the patient has reported a site of tenderness, begin distant from this and work towards it. In addition to feeling for tenderness and masses, you should assess the muscle tone.
Now can you take some deep breaths in and out?
Feel for the edge of the liver as it descends during inspiration. Start in the right iliac fossa and work superiorly by 1 centimetre at a time. If the liver is palpable, describe the characteristics of the liver and its liver edge. Feel for the spleen in a similar fashion.
Again, can you take some deep breaths in and out?
Starting near the umbilicus and working up towards the left hypochondrium. If you do not feel the spleen, you should explore the length of the costal margin, as its position is variable.
Can you roll onto your right hand side, please?
If you have still not felt the spleen, repeat this examination with the patient in the right lateral position.
Take some deep breaths in and out again for me, please.
Again, palpate using your right hand, starting at the umbilicus and working towards the left hypochondrium. Place your left hand behind the patient's left lower ribs, gently pulling the ribcage forward.
And roll back onto your back.
To detect lesser degrees of kidney enlargement, place one hand behind the patient's back below the lower ribs and the other anteriorly. You just need to press firmly, but take care, as this may be tender. The kidney is typically ballottable.
Can I ask you to sit forward, please?
With the patient.
So again, just notice how he went first superficially, then deeply, and he covered each of those 9 regions of the abdomen before going back and doing it more deeply, looking for masses. And then he proceeded to feel for the liver with the hand pointed upward toward the head, and just progressing slowly from the right iliac fossa upward to make sure he didn't miss the liver edge. And then how he came across the abdomen, starting in the right iliac fossa, looking for the spleen. And then you can do that extra maneuver of rolling the patient onto their right side, the right lateral decubitus position, in order to try to bring the spleen down and make it easier to feel. And then he did finish again with trying to feel the kidneys, which can be difficult in an adult, certainly in an obese patient. Again, we'll talk more about the examination of the kidneys when we get to the genitourinary system. So, having palpated for pain and masses and organs, we want to go back and percuss. And it just goes back to, again, that skill we talked about during CS1, where you tap, you put your distal phalanx of the 3rd digit, and you're going to tap it with your hand. And we'll watch a video of this young doctor doing it. And why do we do that? Well, it helps us, 1, check the size of the liver. I'll say that this is not nearly as accurate as doing, say, an ultrasound or something like that, but it can be suggestive. It can help you. So we ask the patient to hold their breath in full expiration. So they're going to breathe out all their air and hold it, and you're going to percuss downward from the right 5th intercostal space in the midclavicular line, and you're going to listen for dullness, right? The lung will be hollow sounding, and as you come down, you'll get a sound of something solid beneath your tapping, and you want to keep going down until you find the upper border of the liver, and then you want to map out the size of the liver by marking that point and then finding the inferior border of the liver and measuring. So that's percussion. You repeat the same process. You can do it for the spleen.
Its edge. Locate the upper border of the liver by percussing down from the 5th intercostal space in the midclavicular line. Measure the distance in centimetres from the upper border of dullness to the percuss over the lower ribs and lateral chest wall to confirm or exclude the presence of splenic duct.
Okay, so it's pretty quick and easy, right? Palpation, then percussion. You're going to feel, you're going to map out the areas away from the pain and then more carefully map the area of the pain, first going light, then going deeper in every region of the abdomen. Typically people divide it into quadrants or 4 parts, or they might divide it into 9 parts, finishing with the area around the umbilicus. And then you're going to feel for the liver. You're going to feel for the spleen. If you suspect gallbladder disease, we're going to look for Murphy's sign in that same area where we're feeling for the liver. And then we're going to go back and do the percussion to help us map out the span of the liver, its size, as well. Try to confirm the presence or absence of the enlarged spleen with palpating across the abdomen to the left upper quadrant. Trying to find just the tip of the spleen. So pretty quick and easy. We're trying to make, again, these videos short and easy to watch and easy to retain the info. And the next video we're going to do is about auscultation and other special tests you can do. You could count Murphy's sign in there perhaps. At any rate, we'll finish with a short part 3 video about those things, and I will see you in the next video.